Good morning, everybody. We are very happy to have with us this morning Professor Thomas Lötscher, the President of the European Society of Cardiology. We are very honored to have him with us. Thank you, Professor Thomas Lötscher, for accepting our invitation and to be in the stand of the Tunisian Society of Cardiology. I'd like, first of all, to thank you for the invitation. We are more than 100 cardiologists, Tunisian cardiologists here in Madrid.
Fantastic.
Because we know that it's a very, very important and wonderful meeting. And I'd like to congratulate you for this amazing meeting, gathering more than 32,000 attendees from all over the world. So it's amazing. And
we have 167 countries.
Yeah. Mm-hmm. And we are here in the global stage with many stands of many national societies. So thank you, and I hope you more success in the future. And I know that you have many projects, many perspectives in the future, and I know that you support us for more collaboration. So my question for this morning is about lipoprotein A, and do you think that lipoprotein A will be an important cardiovascular risk, and particularly in young patients with acute coronary syndrome or coronary artery diseases in case of aortic stenosis? And by the way, it will be probably a therapeutic target in our practice. What do you think?
Well, lipoprotein a is, as you know well, genetically determined. It runs in families. There's also a relation to ethnicity. Afro-Americans have more lipoprotein among Southeast Asians. It's very common. Maybe also in the Middle East, but the data are not really very good yet. And it is a risk factor for atherosclerosis and atherothrombosis in particular. And the data are very strong that this is actually a risk factor. There's no doubt that it is a risk factor. It's dose dependent. The higher the concentration, the worse the outcome. So everybody should measure it once in your lifetime because it doesn't change much. And therefore, once you measure it, you know whether you have a risk factor or not. That's the most important thing, and that's why I suggest you measure it, because when you calculate your risk with blood pressure, your lipids and all these things, it adds independently. So the risk is independent of other lipoproteins and hypertension and all the rest of it. So you should measure it and take it into account for your cardiovascular risk.
And for the treatment, I think that in this meeting, many trials were presented about many treatments, especially RNA treatment, targeting RNA. So what do you think? Is the lipoprotein A will be a therapeutic target in the near future?
Yes, I mean, all products of the liver are very well suited for these sRNAs or antisense oligonucleotides because you can label them so that they go specifically to a receptor on liver cells that's only expressed in liver cells. So the treatment is very specific. And with current technologies, you can reduce Lp(a) levels by 60 to 80 or 90%. So you can almost eradicate the risk associated with this risk factor. Of course, we have to now show that this is actually also therapeutically true. But we know from Mendelian randomization studies where you randomize patients according to their genetic makeup, whether you have a mutation that increases Lp(a) or not, you can see whether there is indeed this causality. And this has been published both for myocardial infarction but also for aortic stenosis.
Yeah.
These Mendelian randomization trials, they clearly show there is causality. Now we have to show that these drugs that I mentioned, these silencing RNAs or the antisense oligonucleotide will be effective. I would be really surprised if not, because their effect size is so huge and consistent, persistent. So I think it will be a very exciting new era for physicians to even better care in a personalized manner, only for those that have this genetic mutation.
Yeah, I think it should be the future, especially for the primary prevention of coronary artery disease and aortic stenosis, especially in families who have, it's a genetic disease, for example, patients who are at high cardiovascular risk. I think.
Well, of course, the likelihood that you will find it is high if in the family they had infarctions with 40, 45. And if you have a patient that is young and has an infarction, particularly also women that be prior to menopause, then you should have a red signal, measure Lp(a).
Yeah.
But ideally, you should measure it in everybody once in your lifetime.
This is the key message, I think. Once we should measure lipoprotein A once a year life.
Yeah, very good.
Waiting for the treatment.
Good.
Thank you, Professor Thomas Lutcher, for accepting our invitation. We are very delighted, very honored by having you with us. And I hope for you more success of this wonderful meeting.
Thank you very much.
Thank you.
Pleasure
Seeing you
here.
in Tunisia.
Yeah.
And seeing you next year. Next year to be the ESC meeting will be next year in
Munich.
In Munich.
Yeah.
Okay. So
Also nice place.
okay. Thank you.
Thank you. Bye.